State for Health and Social Care, Matt Hancock, and his Permanent Secretary, Sir Chris Wormald. We're very grateful that Matt has agreed to appear before us next week because he has to make a statement in the House of Commons this afternoon, which would have limited the time that he has with us. So we're very grateful for his flexibility in that. So I'm very pleased to welcome our witness today, familiar to the committee, the Government's Chief Scientific Advisor, Sir Patrick Vallance. Should also welcome that in addition to members of the Science and Technology Committee, we're very pleased to have Catherine McKinnell, who is Chair of the House of Commons Petitions Committee, joining us today. Sir Patrick, welcome, and thank you for coming before us today.
Thank you, and I'm going to take this off because I can see that we're actually well separated here by 2 metres.
We are indeed. We have at least 2 metres between us all and probably more. Can I start, Sir Patrick, by putting on record our appreciation of your dedication and public service throughout the whole pandemic. You've appeared regularly before the committee and you've engaged very constructively both in person and through correspondence with the committee. Acting on many of our suggestions and recommendations, such as the publication of the names of attendees at SAGE and of papers that SAGE has considered. We're very grateful to you for that. And perhaps through you, we, the committee, can put on record our thanks and gratitude to the scientific community who have been working tirelessly and deploying their great expertise throughout this. We're very grateful.
Well, that's much appreciated, and I'm glad this Select Committee is looking into this because it's important that we learn lessons as we go along.
Absolutely. So in that spirit, and just to perhaps start with some general questions about the way that scientific advice is taken in the spirit of learning as we go. We have, as we know, some of the very best scientists in the world. You've invited many of them to participate in SAGE discussions. Have you found that they've been willing to accept? Have people responded to the call?
Yes, everyone that we've invited to participate has accepted, and clearly we have different people at different meetings, so it's not a membership organisation, it's an organisation that invites people to join as we need them. Some have been at virtually every meeting, others have been at fewer. But in general, and this has been my experience before this as well, when people are asked would they help in a government emergency, the answer is yes, and they turn up and they work extremely hard at it. And I would say that the people who've worked on this epidemic from various different universities have really worked incredibly hard on this. And one of the questions, of course, is how we keep that sustainable for them as the new academic term starts as well.
Indeed. So you've had the pick of British science, which is one of the strongest forces in the world. When you last appeared before the committee, Patrick, you said that there were no significant instances in which the government had chosen to go against SAGE's advice. You quite rightly made a distinction between policy decisions and the advice, but you reflected, and the Chief Medical Officer did subsequently, that they could think of no significant instances in which the government had chosen to go away from that advice. Is that still true? Does that assessment still hold true? Are there any instances in which the government has gone against SAGE's advice?
So you're absolutely right to draw the distinction that SAGE is an advisory body, and of course the ultimate decisions are a mixture of policy and timing, which are not in our control. Those are things that others have to make decisions around. And in general, what I can be absolutely clear about is that those making policy and decisions have heard and understood the scientific advice. That I'm in no doubt about. Clearly, as the pandemic progresses, and indeed as we get into release measures from lockdown, there are many other considerations that need to be taken into account as well as the science, and therefore the ultimate policy position and decisions will need to weigh all sorts of different factors, and therefore difficult to say yes, that's based entirely on science advice, because it's not. It's based on other things as well. But we've given advice, it's been heard, it's been understood, and it's been incorporated into decision making.
And we'll come on to some of the other sources of policy advice. But in terms of recommendations of SAGE, last time earlier in the year, you couldn't think of any significant aspect in which the government had taken a different view from that recommended by SAGE. Is that still the case?
Well, I think it's absolutely the case that government has taken the advice and understood it. And I'm trying to think of an example to express why this is not as you go into more complicated discussions, it's not a straightforward yes-no, in the sense that what we're doing is laying out scientific reasons behind options from which people can choose. And overlaying that with economic and other considerations is the job of government. Clearly, if the government had done something which we said you should not do that, we would stand up and say you absolutely should not do that, in our opinion, from the science.
And that is part of the independence of SAGE.
It's part of the independence, and it's worth remembering that the membership of SAGE is a group of people who come largely from outside government, who are independent and are not paid and are not contracted, and therefore they give their views freely and frankly.
So reflecting as science does, and you are personally one of the most eminent scientists in the country. You're a lifelong scientist. Science is rigorous in confronting theory with evidence. So if we look at the structure of the taking of scientific advice, we've got one of the strongest science bases in the world. People have been willing to serve. The government has explicitly said that it would follow and be guided by the advice. There hasn't been an occasion in which SAGE has felt moved to speak out in public because the government was proceeding without that. So all of that would imply a very strong system for navigating through this pandemic. And yet the UK's response to the pandemic is not the most admired in the world, if I can put it that way. So in your role, have you begun to think about what might be the reasons for that?
Yes, we think about that a lot, and clearly there are things that we do as we go along to keep learning from what's going on, and we're in regular contact with many international partners. I think, as Chris Whitty has said before, it's very difficult to know exactly where we stand at the moment. It's clear that the outcome has not been good in the UK. I think we can be absolutely clear about that. It's also clear that you can see a band of countries that have done less well in the temperate zone, countries that are very well connected internationally, countries that have got population structures which are of a certain type. So there are many factors, I think, that are going to play in as we look and say, well, what is it that makes some countries having done worse than others? And there will be decisions made that will turn out not to have been the right decisions at the time. I'm sure about that as well. I mean, this is going to be a number of factors that need to be taken into account. The other thing I would say is one lesson which I think is a very important one to learn from this pandemic for emergencies in general is that data flows and data systems are incredibly important. You need the information in order to be able to make the decisions, and therefore for any emergency situation those data systems need to be in place up front in order to be able to give the information to make the analysis and make the decisions.
In order to gather data, you need to have tests,
yes.
Do you not? And therefore, in terms of the lack of testing capacity, we might come on to talk some more about that. It obviously has a medical dimension as to knowing who has the disease or not, but it has an information dimension as well to understand the spread and the patterns and who the virus affects and how. And that is that the implication of that?
Well, that's certainly one. It's absolutely the case, and I've said it before, that it would have been absolutely preferable to have had a much greater testing capacity early on. But it's not just testing. It's basic information flows around patients in hospital, around rates of admission, rates of movement. Those sorts of things are important parts of this as well, and making sure all of those systems work. And going forward, it's going to be a number of things from local areas to make sure that we've got the right information flows to make decisions. Those are critical things to be able to get right in this. And testing, was if you go back and look at the minutes, was a preoccupation right at the beginning. We kept saying we need to get more testing capacity in place.
We being
SAGE need to have more testing capacity in place. And of course, it's important to note that the capacity and capability of the public health system needs to be right in order to do this as well.
Just in terms of those data flows, one might have expected, given that we have a national health service, that we would be advantaged in this country in having data flow, and yet you cited as one of the reasons why our performance might not have been as good as it otherwise could be. Is that right? Have I?
Well, I think the National Health Service does provide a fantastic opportunity to do this, and the data flows are really getting much better now. But at the beginning, there were definitely times when we would have liked data that was difficult to get, and that's not surprising in a way, because although it's a national health system, it doesn't have centralised data flows on everything you need, and I doubt that's true in many other countries as well. So I think an improvement in data flows is a key part of management of this and indeed other emergencies as we look forward.
Thank you. That's very helpful to know when it comes to making recommendations for the future. In terms of testing, we'll come on to this in more detail. Who's responsible for testing strategy?
Testing strategy is the responsibility of both Public Health England and the Department of Health, and in terms of how the testing was used and what the priorities were, that was CMO who took accountability for organising that. And
so when you said we, and which you clarified to be SAGE, had said consistently that we needed more testing capacity, that is clear from some of the minutes of SAGE meetings. Did you make that case explicitly to Public Health England and the Department of Health?
Well, Public Health England and DH are obviously both attendees and observers at SAGE. So
was SAGE sufficiently muscular, can I put it that way, in saying we need more testing capacity and it's not coming through quickly enough?
Well, there you're straying into operational and management matters. I mean, SAGE is an advisory body, and advisors can advise, and decisions need to be made as to what the outcomes are. And SAGE doesn't have it can't get into trying to manage things. It just doesn't have the right constituency. It doesn't have the right makeup or authority to do that.
Could it not advise that we need to have more testing capacity based on looking at other countries around the world?
And it did. And in fact, if I go back to papers from the early February, for example, on contact tracing and isolation, paper, I think it was on the 12th or the 24th of February, current PHE capacity to provide it can be expected not to be sufficient or sustainable at the limits of controlling higher rates of incursions. We recommend that a practical, reasonable level of enhancement should be to enable a tenfold increase in capacity. So, I mean, there's clearly an undercapacity issue, which is well recognised, that's important to get right, and that's what's happening now with the ramp up around test and trace and the JBC and other organisations.
Thank you. Just before I turn to my colleagues, just to kind of explore some other reasons why our performance, at least provisionally, does not seem to be at the level of our international reputation in this area. So data flows you've mentioned, testing you've mentioned. Let me just explore another possibility, which is that the scientific method relies on evidence. It prizes evidence, as we know. But sometimes evidence takes some time to acquire, and time can be lost on the way to that. And might it be the case that some countries, I'm thinking in particular in Europe, made policy decisions perhaps in advance of conclusive evidence in an academic paper, but actually allowed these countries to act more quickly than a country which, depending on a very scientific approach, waited for the evidence. And there's one example I would give of that, which was something that was published just last week, which was the Vivaldi study of asymptomatic transmission in care homes. And the conclusion of the study, reported last week, said that the study suggests that care home staff may be at increased risk of contracting the virus, which they may then pass on to others if they have no symptoms. And on the basis of that evidential conclusion, a change in policy was made last week, which was to have weekly testing of all care home staff. Now, is it not the case that actually, without the study being completed, one could have had a pretty good intuition that transmission amongst care home staff, given that we know it could be transmitted asymptomatically, was likely to be important? And therefore, couldn't we have acted in anticipation of that, rather than waiting for this Vivaldi study to report?
Well, again, if you go back and look at the minutes, it's very clear that care homes were flagged up very early on. I think the first record I can find of care homes being flagged up was in February, and there were many after that as well. And it was always the case that there was a worry about people moving between care homes, for example, as a way to spread infection. What you are describing is the policy choices and how those policy choices are made. And I think that's not a decision for me, that's a decision for others as to when and how to make policy.
But if we have a body, SAGE, that is very eminent, and the government has said that it will, for very understandable and high-minded reasons, follow the science, and it waits for definitive conclusions, is that not paradoxically a potential source of disadvantage compared to a country in which policymakers were able to make reasonable assessments of what seemed plausible and likely?
Well, there are two bits to the way you're framing the question, which is the assumption that somehow SAGE has policymakers in its grasp and policymakers will not move until SAGE does something, and that's not the method. SAGE provides advice, and as I say, if you look at the care home advice, that went back right the way to February, and that advice was always, because we're never dealing with certainty, we're not dealing with a body of evidence that says it is absolutely the case that
Yes.
X or Y. We're dealing always with uncertainty, and it's in that uncertainty, and our job is to express that uncertainty to allow ministers and others to make decisions as to which policies they wish to follow.
But
and I don't accept the premise that actually SAGE takes a position which says only when we're 100% certain do we go out and give a recommendation. You can see from the minutes that's not the case. We say there is uncertainty here, but within the bounds of this uncertainty, here is some advice.
But did SAGE advise at an earlier stage that care home workers should be routinely tested?
I can't remember exactly what we've recommended on individual measures. I don't know when we recommended that. We certainly made advice around moving between care homes and other things quite early on.
Okay. And finally from me at this stage, we've had SAGE and it's met very frequently, I think weekly during the pandemic is that the case. We've had our bespoke system. If we hadn't have followed the approach that we had in terms of the structure of scientific advice, and if we had simply taken a decision to follow the World Health Organization's advice at every point, then in February the WHO advice was to have a mass regime of testing, looking at a release statement in March to isolate, test and treat every case to break the chains of transmission. We'd have adopted a social distancing rule of 1 metre. We'd have indicated the use of face masks since the 6th of June. Is there any evidence that we would have fared worse if we'd followed current WHO advice rather than having our own bespoke system of advice?
Well, clearly there's not evidence to suggest one way or the other, but I do want to pick up on a few things on that. I mean, there's obviously earlier things as well, such as those countries which were affected by MERS back in 2015, or looked at MERS in 2015, took actions to get their public health systems and other things ready for this type of thing. So there were signals there that could have been looked at. Your face mask one is a very interesting one, because if you go back, our advice on face masks was in April. And we said face masks are of marginal positive value when used in enclosed spaces where crowding may occur and you can't keep 2 meters distance, which essentially is the advice that WHO have come out with, and is essentially the advice that now forms the basis of policy. So I don't think it's the case that we've deviated from WHO in terms of the advice, and we were rather ahead of it in terms of that particular piece of advice. And similarly on testing, it was clear very early on that we wanted testing ramped up. But again, I think there's a danger of confusing operational accountability with scientific advice.
So in terms of the face masks, obviously there's been the announcement that they're to be mandatory within shops. Are you saying that the SAGE advice was there in April and the policy decision has only just caught up with that advice?
Well, the SAGE advice is there in the public domain to read, and it says when face masks can be of value. Now, it's true that in April and during lockdown, of course, the value of the face mask is rather minimal because most people aren't going out. So it is sensible to think about timing, and this comes back to the point you raised earlier on about material differences between SAGE advice and actions. Timing is a different question, and timing now as we go into release of measures is a sensible time to start thinking about what other mitigating factors you want to put in place. And so, again, for example, making the workplace completely COVID secure in the middle of lockdown would have made no difference because nobody was going into workplaces. It clearly is important now. So I think the timing one, again, is a policy question.
Very good, thank you. Let me turn to my colleagues, starting with Aaron Bell.
Thank you very much, Chair, and thank you, Sir Patrick. Reiterate the thanks of the Chair to you, your colleagues, and the scientific community. If I could just briefly follow up on that face masks point you were making. I think we all recall the Deputy Chief Medical Officer sitting down with the Prime Minister saying how face masks could be not beneficial, and this was before we went into lockdown. Was that based on SAGE advice as well, and therefore has the science changed?
I'm not sure the science has changed dramatically, actually. There's sort of accumulating evidence. It's still not overwhelming evidence, and there are really 3 lines of evidence on face coverings. One is experimental mechanistic work. In other words, if I take this mask and start looking at droplets and so on, do droplets go through it? Or how do droplets get distributed? Or how does aerosol get distributed? And those studies all tend to show, yes, masks can stop things going through them. So they show a high level of protection. And then there's a second level of evidence, which is around clinical trials of what happens when people do or don't wear them. And there the evidence is much weaker. In other words, you don't get 95% protection as you might do if you tested that mechanistically. You get some protection, and it varies according to settings. And then there's observational studies, which we're now seeing, which is what was the impact when masks were introduced in country A or country B, or in environment A or B. Could you see a difference in the rates of infection? They're quite difficult to interpret because usually the intervention isn't a single thing like a mask. All sorts of things, other things changed at the same time. You put those 3 lines of evidence together, and it reaches the conclusion that we did, say I think it was back in April, saying on balance masks have a positive effect in terms of stopping other people catching it from you, not from you catching it from other people. Less evidence around that, and therefore in certain environments there's a role to wear it. I think maybe, and I don't know exactly the context, but one of the things that the Deputy CMO may have been worried about, and it remains an issue, is if you wear masks for very prolonged periods, people tend to fiddle with their face a lot, move them around, take them off and so on, and then it's actually a bit more tricky to see what the benefit is.
Thank you. And just again on that, there's been some suggestions that one of the reasons that the Deputy CMO and presumably by extension SAGE were setting that position out in the first place was to discourage people from buying up all the supplies of face masks at the time. Is that not the case? I mean, it was purely a scientific decision rather than an operational one.
Again, I think it's quite important to recognise that SAGE doesn't give all of the scientific advice. SAGE is a group to give certain aspects of scientific advice in certain settings. So not every utterance on science comes through SAGE or is approved by SAGE. And there's a whole system of public health and other things that make decisions based on science, which they've got all sorts of reasons to do. I think it is the case that there was a real concern, and I think the CMO was clear about this, that the situation in which medical grade masks are clearly of value and very important is in healthcare settings, and therefore there was a priority to make sure that those healthcare settings had those masks. I think that is clear.
If I could turn now to immunity going forward, what's the latest scientific evidence, what's the latest understanding of SAGE on how long the immune response lasts and what are the implications for our future strategy?
Yeah. What's become much clearer over the course of this outbreak is that the vast majority of people who get COVID get an antibody response. So in, for example, an outbreak setting, it looks like it's probably 95% of people get antibodies. There are papers suggesting a bit less, but it depends on the sensitivity of assays. But the vast majority of people get an antibody response. It looks like most of those antibody responses contain so-called neutralizing antibodies, so antibodies which would be expected to actually reduce the ability of the virus to cause an effect. It also appears that in some cases, it's not clear what proportion, in some cases antibody levels seem to drop after about 3 months or so, or in the run-up to 3 months. So antibody responses may not be long-lasting. That does not mean that some form of immunity is not long-lasting. So we've got other parts of the immune system. We may have memory cells on the B cell side of things. We may also have T cell responses, which are important, and we don't know. So there's much we still don't understand about immunity, and we don't know to what extent a positive antibody means that you are protected against the virus or indeed protected against carriage of the virus. So we know more, but lots of things we still don't understand about immunity. I say we do know now that most people get an antibody response.
Thank you. I'll hand back to the chair because I know we're short of time.
Thank you. I think Andrew had a question on the structure of scientific advice. Is that right?
Yes, thank you. Thank you, Sir Patrick. And thank you, Chair. You've been at the central to a unique set of circumstances. Obviously, it is the first time we've dealt with this matter. I just wondered yourself what lessons you have learned to date as you reflect about the next stage that we have to manage, or indeed future pandemics.
Well, lots of things, and we're in the process of really taking a deep look to see, what are the things that we must concentrate on and get right. Things that I would reflect on. Number one, as I say, in any emergency, and I think this is an important lesson across not just pandemics, but every emergency, data. Must have the data flows, must understand data ownership, must understand how data is going to get to the people for the information you require. So that's point number one. The second is that when I look at the structure and the way that SAGE operates, it's never been set up to work for 47 meetings. We're meeting twice a week for most of this, and we need to think about how to make that work. It's largely volunteer academics who've helped out. They've gone over and above to put their advice into the system and to help in all sorts of ways. I think we need to think about resilience of that system. The third point is that, and it really speaks to the last question to some extent, the science system across government and across agencies needs to be robust. SAGE is not the science system, it is a science advisory body. And so science within Public Health England needs to be in the right place, science in departments needs to be in the right place. There needs to be enough in order to be able to take the science advice, or indeed other science advice, to feed in. And the other thing which I think has been important, two other things maybe just to mention. One is that it's been really important that other bodies have stood up to be able to give science advice as well. So, for example, it's been incredibly helpful that the Royal Society has set up its groups to feed in. The report from the Academy of Medical Sciences that we commissioned on winter, very, very valuable. Royal Academy of Engineering have been fantastically helpful around aspects of engineering advice and so on, really useful. And then my final comment is, and it speaks to some extent to the point the chairman was raising on the docking mechanism of science into policy and operations. And I think it's really important that that works effectively. Traditionally for SAGE, that mechanism has been via the Civil Contingency Secretariat and into COBRA. And obviously in a long-lasting episode like this, other mechanisms have had to sort of be invented in order to make that happen. And I think that's a really crucial area.
Thank you. I think we look forward to hearing more about that another time. So I'll ask one more question and then we'll just move on. Is there any part of you, as a champion and an esteemed scientist in your own right, that makes you worried that science has perhaps been overweighted in the conversations around how we as a government and as a parliament have managed this pandemic? And to cast a thought on that, have we lacked for a business or an economic SAGE? If you felt that science as one limb has been strong and has had a strong voice at the table, perhaps in the initial stages of managing the crisis, there are other constituencies that lacked for a similar structure.
We thought hard about that actually, and we thought about to what extent economics, for example, should be integrated into SAGE. It was quite a difficult thing to do, and Treasury, of course, has its very strong economic advice, and so that does come together through another route, and that gets integrated in Cabinet Office procedures in order to get those two things joined up. So I'm not in doubt there's been an extremely strong economic voice that's been heard throughout this, and a business voice as well. But I think, as both the Chancellor and the Prime Minister have said, you don't get economic success unless you also get control of the epidemic. So there was a sort of, if you like, a first order thing, which is to get control of the epidemic.
Professor Mark Woolhouse gave evidence to the committee. He's one of he's I think advised on the modelling side, the epidemiological side of SAGE. And he told the committee, I do think scientific advice is driven far too much by epidemiology, and I'm an epidemiologist. And what he said was, I was particularly concerned that we were looking at only one side of the equation when assessing the costs and benefits of lockdown. The other side is the harms done by lockdown. By those I mean the harms in terms of reduced access to healthcare provision, harms to mental health, and the impact on the economy. So would it not have been better would it now be better to have within that structure of scientific advice what Professor Woolhouse refers to as that side of the equation?
Well, I think it was there, and it wasn't only there in terms of some of the representation at SAGE. So we have a Treasury economist on SAGE, and we also have got several people who've got the background in that area. But it isn't the purpose of SAGE in this to look at that. But I will point to the, I think, very clear comments that the Chief Medical Officer has made about this, and I think he was very clear very early on, actually, that there were downsides to this from an economic perspective that would have significant health effects. And he talked about the ways in which damage could occur as being direct from the virus, indirect from the virus because you've got overwhelming of the healthcare system, which leads to problems, indirect because of economic consequences of lockdown. And so there are ways in which this was really discussed very early on as a risk, and we've been worried a lot about the consequence of this, and I think those worries are right. Now, could the economic input be different? Could it be stronger? Could the science input merge with economic input in a more effective way? I mean, the answer's got to be yes. There must be some way in which you could look at that and make it better. So I'm not arguing that things are perfect, but I think it's incorrect to say that they weren't there at quite a prominent position, even quite early on.
Has Sage made an assessment of the impact of the lockdown, the indirect impact in terms of lives and health?
Well, again, I think CMO has really been pretty clear about this, that the way that this should be looked at is overall excess deaths. Mm-hmm. Because if you look at overall excess deaths, then you're looking at the integrated effect of the virus itself with all the other reasons that people may have suffered as a result of this. And there's a lot of work going on that, trying to get a good handle on that. It's not an easy thing to look at when you compare across countries because people measure these things differently. But I think it is crucially important. And we do need to understand the impact of that. And it's very clear that lockdown itself carries risks. And those risks are both physical health and mental health.
And presumably they express themselves in terms of excess deaths, sometimes over the very long term.
They may be very long term, and we've had groups looking at this, led from both ONS and other parts of the SAGE group to say, how do we get our handle on the excess deaths and what the origins of those are?
Thank you. Dawn Butler, and then Mark Logan.
Thank you, Chair, and thank you, Sir Patrick, for all of the work that you're doing. The World Health Organization is rethinking how COVID-19 spreads in the air. 239 scientists from 32 countries talk about floating virus particles that infect people who breathe them in. Do you agree with this science?
We do, because we said that in April. And one of the signatories to that letter is the chair of our environmental modelling group, Kath Noakes. And if you look at the papers, we've argued from the beginning that there are three potential routes of transmission: aerosol, which is the one that the WHO is talking about now, droplets, and surface contact. So I think it's clear that all those three are things that need to be taken into account. What we don't know, and interestingly, we do not know this for flu yet either, is what the relative importance of the three different routes are. So that, I think, is the really crucial thing. If it turns out that 90% is aerosol, which I think is unlikely, then that would change things in terms of how you approach this. So it's the relative contribution rather than is any one of them important. We think all three are important, and the advice that we've given, with bounds of uncertainty, has been based on an assumption that all three routes can occur. The one that we don't think is such a big area, and the WHO doesn't either, is a very widespread airborne transmission of the type you can get with measles and so on. We think that's less likely to be an important factor.
Absolutely, because I understand that it can stay in the air for up to an hour. So just to ask you, if there was a queue of 300 people in a line, would you want to be at the front of the line or at the back of the line?
Well, all sorts of questions there about where you want to be in a line anyway. But I think if it's outdoors, the risk of transmission is low, and we see that. And we also see from some of the demonstrations and so on that have taken place over the last couple of months that you don't so far we haven't seen an uptick in cases as a result of that. So I think outside, the risk of transmission, particularly if you're keeping distances, is pretty low. Inside, if you were in a big queue and that queue wasn't distanced, then it shouldn't be taking place.
Thank you.
And sorry to interrupt. So for three actions, can you rate them for me? And I'm specifically referring to Parliament, actually, and how Parliament is currently voting. If you could advise the government, would you advise the government that members of Parliament should vote online, wear masks, or stay in a line of 300 people whilst voting? How would you rate that advice to government?
Well, I think science advice here is not policy advice, and therefore my advice is, as is laid out in our papers, that when you're indoors, if you cannot distance and you run a risk of being crowded, then you have to have other mitigating measures. And those mitigating measures can include ventilation, face covering wearings, hence I was wearing a face covering when I came in because I didn't know what the situation was when I walked into this room. Hand hygiene, making sure that you are apart from people, and ideally 2 meters apart still remains the optimum if you can do that. And so I think those are the sorts of measures that can be put in place in situations where you can't actually avoid doing an activity. I think the policy on how you do that is not my decision.
Thank you.
Okay. Thank you. Mark Logan.
Yeah, I understand that. I think the science advice is clear. Thank you, Chair. I had.
We'll come back, Don. You have another chance. Mark Logan.
Patrick, just my thanks for everything you and the science community have been doing throughout the pandemic. And I just have a few questions around face coverings or face masks. Just out of interest in the face covering you were wearing at the beginning of the session, what sort of special features does it have?
Well, it's a fairly standard cloth face covering. Got a nose thing to make sure it doesn't slip off my nose, and it's got several layers.
How often, this one, would you suggest, how long would you wear that for? Do you wash it, or is it just single usage?
Well, I think you should wear them for short periods. As I say, I don't think it's something you can wear all day in indoor environments. There's some evidence for that. And yes, like my other clothes, I wash it.
Okay, thank you. And then, is there a placebo effect or psychological boost, do you think, from wearing a mask that might positively impact immunity?
Well, I think it's a reminder. You can see from wearing a mask that people are taking, when people are wearing a mask, it reminds you that there are things you need to do. So I think there are, positive benefits to the messaging that might come with that sometimes.
Then I'm interested to ask just that YouGov and Imperial College London had polling recently which showed that the uptake of wearing masks in the UK was much lower than a lot of countries that they polled. And then I did my own polling on Facebook overnight where 470 people in Bolton, actually I found that 71% of people support wearing a face mask in shops, for example. So what do you think explains this kind of divergence between the actual practice of wearing masks in the UK and people's intentions?
I'm not sure that I have a clear answer to that. I think there is something about messaging to make sure that people are aware what the importance is and in which circumstances. I think it is important that people understand about the duration of wearing. It's very difficult to wear them all day, as I say, and therefore you need to think about how to manage that. And I also think some of the polling on what's happening in some other countries doesn't quite seem to align with what you see. So some of the figures suggested that 70% of the US was wearing them. I'm not sure that quite fits with some of the pictures you see. So I don't know whether we're different in that. But you do hit on an important point, which is many of the responses to measures are quite culturally determined, and therefore we need to make sure, not just as the UK as a whole, but in different communities in the UK, that both the messaging and the awareness of the cultural issues are taken into account in that messaging and the engagement.
And just two final questions. One is, roughly how many masks do you think that we will use now on a weekly or monthly basis, given this new advice as a country? How many do we need?
I don't know. I'm sorry, I don't have a figure for that.
Do you think low millions, tens of millions?
Well, it's likely to be many millions.
Okay, great. And then finally, just on schools, this morning I visited Eden Boys, Cansley and Valley Community Schools in Bolton. The head teachers had some questions just specifically around can schools actually permit staff and pupils to wear face coverings if they wish to do so in some circumstances, and can they ask for face coverings to be worn?
I
didn't catch the last part of the question, but
can they ask for them to be worn for prolonged periods? I think that was right, is it, Mark?
Well,
that's right. Yes, sir.
It's not really a science question. It seems to me that that's a straight policy question, and one for the schools. There's nothing scientifically to say don't wear a face mask. There's lots of science that says there are certain situations in which it's beneficial. There is a problem, and it's an important one, that clearly it's not practical to ask small children to wear face masks, and it's not sensible to do so. And the evidence in terms of the role of children, both in terms of their susceptibility and indeed potentially their lower role in terms of transmission, suggests that would not be a sensible route to go down for small children.
I think.
Sorry, on that. The UK advice said aged 11 and below, there isn't guidance to wear face masks. But I noticed, I think it was in Spain, they have the age limited around 6 years old. Is there any reason for that? Is there a risk for younger children to have a face covering on?
They just don't tolerate it. But I think, again, it's quite an important discussion in the sense that what we're straying into here, and this is where it's worth me just making a distinction, SAGE is not giving advice on detailed operational things. That will come straight out of DHSC and the Chief Medical Officer's office, and in many cases for businesses and so on, it'll come out of BAYS and so on. Those are operational matters. We haven't looked specifically at an age cut-off at which masks become not usable in children. We've said small children, it doesn't work for all the reasons you know, but we haven't given a precise age cut-off.
Thank you. I think you did say, Patrick, that prolonged use indoors was not recommended.
Prolonged use indoors for routine workers is very difficult, and that comes with all sorts of problems.
Right. And I'm interested in what you said about not getting into the detailed advice. That's not for SAGE. So SAGE is taking, as it were, a kind of broad set of advice on decisions. So when the Prime Minister asks for scientific advice on whether a cricket ball is a vector of disease, it doesn't come to SAGE. It goes to somewhere else.
Well, I'll give you two examples. If you take the advice given on environment and COVID-safe environments, we produced a number of papers which are in the public domain, which gave a series of principles around that and how that could be applied. What we didn't do was go and say, in this particular office configuration, it needs to look like this. I mean, that's obviously something that is a much more detailed operational matter inside a department or indeed inside a business, and that's where the science advice in departments need to step in. In terms of a cricket ball, no, cricket ball did not come to SAGE.
Right, thank you. Graham String.
Sir Patrick, as a scientist, I was always taught, forget your hypotheses, forget your theories, your ideas, look at the data. And, because having preconceived ideas can distort the way you look at things. When we went into this, scientists in this country were looking at data coming from China, which showed a doubling of the infections every 6 or 7 days. When you looked at our data closely, the infections death rates were doubling every 30 hours to 36 hours. Why didn't you and SAGE advise the government to change their attitude? Because if you'd looked at that and given that advice, the lockdown might have happened earlier.
Okay, two things on that. The first is quite an important one as we look back and try and decide what should or shouldn't have happened, is we focus on lockdown, whereas actually there were a series of steps in the run-up to lockdown which started with isolation of people who come in from China, but the main ones were case isolation, household isolation, then recommendations not to go to pubs and theatres and so on. And if you look at what the behaviour change was, it was quite extreme over that period. So there's a number of things that happened. But your point about timing is absolutely right. And when the SAGE subgroup on modelling, SPI-M, saw that the doubling time had gone down to 3 days, which was in the middle of March, that's when the advice which SAGE issued was the remainder of the measures should be introduced as soon as possible. And that advice, I think, was given on the 18th of March or the 16th of March, I can't remember. And it's when those data became available. Now, looking back, you can see the data may have preceded that, but the data were not available before that. That knowledge of the 3-day doubling rate became evident during that week before.
And did it immediately affect the recommendations on what to do?
Well, it absolutely affected the recommendations on what to do, which was to say the remaining measures should be implemented as soon as possible, I think was the advice that was given.
You also said at one stage, I think it was again in early March, that we didn't need to take such drastic action immediately. I'm paraphrasing it, that might not have been your exact phrase, because we were 4 weeks behind Italy. Again, it became, at that time our deaths were quite low. Deaths in Italy were at about 1,000. About 12 days later, we reached that number of deaths. So it was clear then that we weren't 28 days behind Italy. Did you respond to that change in the data, and if so, how?
Well, I think it's exactly the same timing. I haven't got the numbers, exact numbers you're talking about, but it's mid-March when it became obvious that this was accelerating faster, and we were closer than it had seemed. And at that moment was when the advice changed to say implement the measures as soon as possible.
So the advice changed because we realised we were not 4 weeks behind Italy, and the infection rate was about twice what we thought it was to start with.
The advice changed because the doubling rate of the epidemic was seen to be down at 3 days instead of 6 or 7 days. That's what it was. I mean, we didn't explicitly say how many weeks we were behind Italy as a reason to change. It was the doubling time and the realisation that on the basis of the data, we were further ahead in the epidemic than had been thought by the modelling groups up until that time.
Those figures indicate, which has always been stated by people, I guess, who couldn't define what exponential meant, that this disease was increasing exponentially. Michael Levitt's sort of Nobel Prize winner has recently done some work which states that it's his conclusion that while the virus starts spreading exponentially, it levels off and it follows, I've written it down, the Gompertz curve, which is a well-known biological curve. Are you aware of that work, and has it informed any of the recommendations?
Well, at the time, it didn't inform those recommendations because it was exponential at the time. It was doubling every 3 days.
Yeah, at the start. But he's saying that
at some point it slows down. At some point, it would slow down. That's
yes.
right. But I mean, we didn't get anywhere close to that. And so, no, is the answer.
So, no, you weren't aware of the work, or no, you didn't take it into account?
Well, no, we did not consider that we were anywhere close to this moving from an exponential to a non-exponential curve at that moment.
Right.
And the modelers, I mean, look at all of these things the whole time and give information on it. But I mean, in order to do that, you need to be much higher up the epidemic curve before you start to level off. We were nowhere near that.
And can I just ask one, I know we should press for time, if I can just ask one question related to your first answers to Greg. You said that there was some information not available in the NHS, but you didn't give any examples of that. Information that would have been useful had the information flows been there. Can you give us some examples?
Yeah, I think probably the best thing to do on that is that we get you something from the SPI-M modelling group on the data flows that actually would have been helpful earlier on that took a while to get together, and then we've got a record of those things. And again, that's absolutely not to say that people weren't trying very hard to do it, but these things are difficult to get right. And there were definitely some data flows that they would have liked to have seen earlier that they couldn't get.
Can you give us an example?
Well, I'd rather give you a written the detail, because these are the detailed inputs to models. And so, it is things like the exact time-bound admission rates, death rates, ICU rates, and so on. Those things become really important to get accurately from all sources information from care homes, those sorts of things become important information flows to be able to get these models right. So rather than me give you a list now, I think we get the SPI-M to say, well, these are the things we would have liked to have had that we couldn't have at the right time. This is when we would have liked to have seen them.
We'd be grateful for that, but in the next few days, if
we'll do that. Yeah.
Okay. Thank you very much indeed. Carol Monahan, and then Zara Sultan.
Thank you, Chair. Thank you, Sir Patrick, for the information you've given us so far. Can I ask, first of all, in the last 24 hours, we've heard that the Randox tests have been removed due to queries regarding safety standards. Are you able to tell us anything about that?
No, I'm sorry. It's not part of what I look after. That's obviously part of testing in DHSC.
Okay. And so have you any idea at all, and if you don't, that's okay, removing these tests, how big an impact that will have to the whole test and trace system? No,
I'm sorry, I don't have that information. That's, again, one for DHSC and the testing and tracing people. I'm sorry.
Okay, well, a lot of my questions are about testing and tracing, but the next thing I'm wondering, and again, any information you can give us is useful. Hearing from people that are working in the tracing centres, many of them are struggling to get contacts to answer phones, possibly because it's coming up as a withheld number. Are you aware of that, and is there any moves to allow the callers to see the number that's calling them?
Again, these are operational matters for test and trace. They are not things that would come to me as Chief Scientist and not part of the SAGE area.
And that's the responsibility, just to be clear, of Public Health England and the Department for Health and Social Care.
Yes.
And the Permanent Secretary and the Secretary of State will be appearing before us on Tuesday, so we'll be able to pursue that. Sorry, Carol.
Thank you, Chair. Sir Patrick, SAGE advice states that at least 80% of contacts of a confirmed case need to self-isolate for the system to be effective. Now, currently, 77% of positive cases are identified and only 76 of their close contacts are being asked to self-isolate. So I would reckon that means we're only hitting about 50% of the contacts. So can this system currently be described as effective?
Well, we put what we thought was a target that should be aimed for, because we think that is a way in which you get control of this. And I would agree with what Dido Harding has said, which is the absolutely key thing is to get anyone who's got anything that they're worried about in terms of symptoms to get tested, because increasing the number of people identified who are positive with symptoms will then allow the rest of the system of contact tracing to work as well. So I would really concentrate on getting the number of people tested with symptoms up, however mild those symptoms. And you can see why it's been difficult, because at the beginning the message was don't get tested because there wasn't testing capacity, just isolate yourself. And now the message is, even if you've got something mild, go and get tested, and that's the important thing that we need to get across.
Of course, one of the difficulties we have is a large proportion of people that are testing positive for COVID appear to show no symptoms at all. Is there any way our test and trace system can actually more proactively seek out positive cases rather than relying on those that are symptomatic to come forward?
Yes, and here we have given advice which is on testing high-risk environments and high contact occupations as ways to do it. So we know that some occupations are much more likely to come into contact with lots of people, and there's also evidence from the ONS survey that those occupations end up with a higher risk. So there are occupations and there are environments. I mean, the obvious ones are meat packing and so on, where we know there's an increased chance. Those are places to go and look for cases. And then where you have an outbreak or where you see an increase in numbers in a city, a region, a locality, that's also a time to go and test more in terms of asymptomatics.
Do you see that there would be a more proactive approach taken when schools return? Scottish schools are currently on summer holidays. They'll be returning mid-August. English schools will be returning hopefully to a more normal situation in September. Is there any plans in place to test staff that are working in the schools and frontline staff in, for example, care homes or in shops?
Well, again, you talk about testing policy here now. I think the current situation is that testing is taking place in care homes, both staff and patients, I think once a week. So I think that is happening. What we are doing, what we've recommended and is underway in schools is a surveillance study to try and understand what the incidence and prevalence is in schools. So that will be going on, it is going on already, to try and get measurements on that. Then there would need to be a policy in place around which makes sense on the basis of that survey in terms of testing. And I reiterate the point that the evidence around children in this disease are, number one, they get a much milder disease. The evidence of severe disease, except in a small, very small minority, severe disease is extremely rare in children. Second is, there's some evidence that they may get infected less. Here the evidence is less strong, but I know the report from the President of the Royal College of Paediatricians and others, and Ros Ego from London School of Hygiene and Tropical Medicine, suggests that overall children are at reduced risk of catching it. There's some controversy around that because the antibody tests don't always support that conclusion, but some evidence of reduced infection, and there's some evidence that they have reduced transmission as well. And when you look at countries where they've reopened schools, schools are very seldom the cause of the outbreak. They're quite often the consequence. In other words, you get an outbreak in an area and a school gets infected, but schools don't seem to be a major cause of the outbreak wherever they've been looked at.
Thank you. Can I come to Zara, Carol?
Yes, thank you, Chair.
Thank you very much, Carol. Zara Sultana.
I've got a few questions, but just to start off, Sir Patrick, how would you define a second wave of COVID-19?
Well, we're not. When people talk about second wave now, actually, what I think they're talking about really is a re-emergence of the first wave. All we have done is suppress the first wave, and when you take the brakes off, you would expect it to come back. That is not the same as the classic way people think of second wave, which is when the whole thing's gone away down to low levels, it comes back again next year. And that's sort of the seasonal thing that's been seen with pandemic flu, for example, in 1918. And we don't yet know whether this is a seasonal virus, but there are some, I think, pretty strong hints it may well be. And so a second wave is more like this thing going around the world and coming back again. What we're dealing with now is a suppressed first wave, I think.
And what is the likelihood that the UK will experience a second wave? And what would you recommend the single most important thing being to avoid that situation?
Well, I think there's a very high likelihood that come winter we will see an increase in cases. And I think that was described very effectively in the Academy of Medical Sciences report, which we commissioned. I think that's likely. That's you could argue that's the tail end of the first wave, still there, coming back. And I think it's quite probable that we will see this virus coming back in different waves over a number of years.
UCL and London School of Hygiene and Tropical Medicine researchers argue that fully reopening schools in September and parents returning to work without an effective test and trace programme could trigger a second wave. Do you personally agree with these findings, and do you think schools are adequately prepared in terms of contingency planning for a second wave or even localised lockdowns?
Well, I don't, again, depending on the definition of second wave, I don't think schools are going to trigger a second wave. But any measures that you release could allow a recurrence of the first wave, as it were. I think everyone, including the representative of the London School of Hygiene and Tropical Medicine on SAGE and the modellers from there, believe that schools are relatively lower risk than other things in terms of opening. one of the important areas that we need to look at is to make sure there's enough room for schools to open, because we absolutely know that there are risks to keeping schools shut. So I think SAGE, the modellers, and the consideration from the subgroup that we've got working on schools is very clear that we think that reopening schools is a priority. It's important for children. The President of the Royal College of Paediatricians, again, Russell Viner, has been clear that there are unwanted health and both mental and physical health problems with keeping schools shut. And schools, for the reasons I've said, children are at lower risk, and actually teachers are more likely to be at risk from other adults and sitting in small coffee rooms and so on with other adults than they are from the children themselves.
Thank you. I'm just going to ask some questions just about the app. So in a committee session that we had on the 24th of April, Professor Whitty said that contact tracing done the old-fashioned way, i.e. not using an app that takes a lot of the heavy lifting, is unbelievably labour-intensive to do. Do you agree, and how can a test and trace system effectively work without an app?
Well, contact tracing is very labour-intensive, and it exactly goes back to the point I made earlier on, that the test and trace system, or the tracing system that was in place actually in February, was not one that we didn't like. We wanted more of it, but it was very difficult to scale that on the basis of what Public Health England was able to do at the time. The app can help. I think a well-designed app that works, you could imagine, could help. Just worth reflecting, though, that the modelling that's been done suggests that if 30% of people were using it, you'd roughly have a 9% increased detection rate. So, you've got to get very high levels of use in order to get significant effects, which is obvious, because what you're trying to do is to pick up those contacts which you wouldn't pick up from memory, but you'd pick up because your phone or whatever had told you were close to somebody. So I think there is an absolutely a role here, provided this can be done properly. And it hasn't been easy anyway. I mean, the idea that lots of people have got great apps working on this is not correct. I mean, they've got some aspects of great apps working.
Just my final question. The NHS has spent £11.8 million developing and testing the NHS X app. It's faced technical problems, severe delays, and was eventually abandoned. We've also seen £32 million handed to a pest control company to source surgical gowns, and £16 million in April to get antibody tests from China that were shelved because they didn't work accurately. I appreciate this isn't a scientific question, but do you share my concerns on how public funds have been used during this pandemic?
That sounds like a question for the Secretary of State for DHSC to me.
Fortunately, he's coming on Tuesday, so I'm sure Zara will ask that. Patrick, do you think people should no longer work from home if they're not vulnerable or living with vulnerable people?
I think my view on this, and I think this is a view shared by SAGE, is that we're still at a time when distancing measures are important, and of the various distancing measures, working from home for many companies remains a perfectly good option, because it's easy to do. I think a number of companies think it's actually not detrimental to productivity, and in that situation, absolutely no reason I can see to change it.
We have discussed the importance of the indirect effects through the economy.
Yes.
And the Governor of the Bank of England is reported to be concerned about people working from home. Companies may be able to manage with it, but if their workers are at home, they're not in shops and cafes and using public transport. Has that been part of your assessment in making this
we haven't been asked specifically to look at that question, but it clearly is part of the assessment, and that's where the integration of the economic, business and science comes together, and I've certainly been involved in those discussions.
It's urgently needed, isn't it, that assessment?
Sorry?
It's urgently needed, that assessment.
That is exactly what's going on in Cabinet Office with Treasury, and those things have fed into the decision-making process.
Right. So outside SAGE...
That's not... SAGE can't advise on that. So SAGE's advice would be on the principles is in a way quite easy, which is the likelihood of the spread of the virus is dependent on contacts. Mm. So the more contacts you have at close range, the more likely this is to spread. And that principle underpins a lot of the advice. then clearly the decision, for all the reasons we've talked about, including the economic impact of this and the impact of that on health, need to be integrated in terms of final policy decisions.
But that assessment, the economic impact, is relevant to lives and health. So is it right that that should not be part of SAGE, that SAGE should just look, as it were, at the transmission and not at the health consequences of some of the measures?
So we do look at, as I said, and again, I'll go back to CMO, I think has been absolutely clear about this from very early on. The health impact of lockdown and measures we consider, but not in a modelling sense. We're not modelling that. We can't, because we don't have the economic modelling. But that is done, and that is then integrated at a cabinet office level in terms of the people around the table, which usually or always includes either CMO, me or both of us, or other scientific representatives to make sure the epidemiology and the other side of it is properly understood in relation to the business and economic decisions that need to be made.
I see, thank you.
But I think it would be wrong to think that that's a way that SAGE should do that. I mean, I think it's going to become a very big distraction to what SAGE needs to concentrate on.
Well, as long as someone's doing it.
Yeah, it is being done.
Yeah. Catherine McKinnon.
Oh, hello, hi. Sorry, I've just come back on. I've totally lost all connection, so thank you. I'm really sorry that I've just missed the bit just before.
Do you want me to come back
here,
to you,
so
Catherine?
if I repeat something somebody said, I apologise. I'm very grateful to be here. There are a huge number of petitioners interested and concerned in this issue, so it's good to be here in that capacity to represent some of their concerns. I wanted to follow up on some of the questions that Zara was asking about the track and trace system, and I'm really sorry though that I missed the answer that you will have just given about the app and taking some of the heavy lifting out of the old-fashioned way as Professor Whitty described it. And I wanted to explore how, in the absence of an app, we maximise our ability to track and trace, because it clearly is one of the most important things we can do to get ahead of the virus now. And so it would be helpful to understand from you what level of data we need to have available to the local public health. And I know this is a responsibility of Public Health England, but just in terms of the data, if you could explain how we ensure that the track and trace system is as effective as possible in the absence of an app that would be doing some of that work for us.
So two different questions in there. I'll just repeat what I said about the app. I think the app is an important potential part of this, but it's worth remembering if you have 30% of us all using it, you'd increase the number by about 9%. So we shouldn't think of the app as the answer to the problem. I'm afraid there's some rather boring, old-fashioned boots on the ground type thing that needs to happen in contact tracing, which is what's happening now, and the app would be a supplement to that and a useful one were it able to be fully functional, and it's not easy to get these things fully functional anywhere in the world. So that's the first point about that. So I've slightly forgotten the other part of the question now.
No, so the question is
the data flow.
In order to maximise those boots on the ground, so to speak. As you said, it was very effective when the local public health teams were able to do what they do, and they do it very effectively in tracking down public health issues, and they were doing that in relation to coronavirus. And obviously it then became a much larger, and it needed to be scaled up, which is why then it became a national effort. And there's now 18,000 track and traces. The problem seems to be, and this seems to be coming from a number of directors of public health, that the two don't seem to be working together necessarily, and so you're not getting the adding up together of national ability to track and trace with local intelligence that's really vital for understanding how best to tackle it in local areas. So I wondered if you could comment on that.
Well, I strongly agree that this is a very important thing to get right locally, and the information flows need to be right. And the new Joint Biosecurity Centre is set up precisely to try and make sure that the data flows are there and they work and they get out into where they need to be, which is the local areas. And you're quite right that the local public health teams and local public health directors are absolutely critical in this, because we've moved from a stage of thinking of blunt lockdown across the whole population to being able to release some of those and then rely on much more local action. And local action can be as local as this one building needs to be looked at.
Yeah.
That requires really good information flows, and it requires Public Health England on the ground, and it requires JBC to be linked to that. And I know that's what people are working on, and those are very key operational matters to get right.
Thank you.
Yeah, and we're not there yet. And I think one of the challenges is that the level of data that's being provided is at postcode level. I think that's as granular as it gets. But even if you live at the same postcode, you don't necessarily attend the same church, you won't have been to the same swimming pool, you won't go to the same pub. And so the ability to actually get ahead of this virus does seem to be hampered by the data at the moment.
I agree, and it's the granularity of that data, and things like, where you live isn't necessarily where you work, and those sorts of bits of information are really important.
Thank you.
And the speed as well. Sorry.
Thank you very much, Catherine. Graham Stringer, and then Erin Bell, and then Catherine Fletcher.
Thank you. Can I just, I've got some questions on testing. Can I just ask a couple of questions on your previous answers? Right at the beginning, you talked about the problems in care homes. Was it, and that was discussed at SAGE, we were told right at the start of this epidemic that if this bug got into care homes, we were likely to get 30-40% deaths in the care homes, based on evidence from Washington State in America. Did you do a risk analysis? Most of the reasons given for not providing better protection have been about testing in asymptomatic people. But was there not a risk analysis done at the start of this process?
That's really a matter for DHSC. I mean, it's not a scientific question.
Well, why?
Well, we flagged up that care home. They have the accountability for that sector. And so, again, SAGE is not the organisation that manages these things. We can give science advice.
I'm not asking a management question, Sir Patrick. I'm asking a question about understanding what the risk might be. That's a data question. It's a question about understanding what potential damage might be done.
Oh, sorry, I misunderstood. I thought you meant risk assessment of care homes. In terms of literally going and do a risk assessment, which is...
No, I wasn't individually. No, I was talking... Professor Ferguson told us, again, right at the start of this process, that care homes weren't part of his models.
Right.
They didn't go down to that level of granularity. What I'm asking you, given that it was known, and amongst advisors, that this would be catastrophic, and we've had 25,000 deaths. Why wasn't a general risk analysis done so that policy options could be put forward to say what would be the best way of ameliorating this risk?
Well, I think there were... I mean, on the first point about models, the reason they're not in the models is they didn't have the data. So the data were not available from care homes to put into models. And that comes back to my general point about data, because you can't model something if you haven't got the data. And then in terms of was risk identified, risk was identified. And there are papers showing the risks, the sorts of risks, and again it comes back to some basic principles, such as people working between care homes is a risk, imported cases are a risk, spread within care homes are a risk. So those principles of risks were described, and therefore those are things that need to be taken into account. And you can see this was clearly the case, by the way, right the way across Europe.
But there were no policy decisions. There was no action taken, was there? I mean, what were the recommendations? We know there was a risk. We were told if the virus got into care homes, there were likely to be very many deaths. But there seemed to be no process between knowing that basic fact and people on SAGE and scientific advisors saying, right, if that happens, what policy options are we going to recommend to government?
We don't recommend policy options.
Well, I don't want to fence about words, but what advice we can give to government?
I've just listed some of the advice we gave, and I think how that is utilised is not a responsibility of SAGE. Now, we give the advice is laid out clearly, the advice is in the public domain, people can see the advice that we've given in these matters, and then it's a matter of operationalising it, and that clearly is not an accountability of SAGE.
Right, I'll move on. I'm not totally sure I completely understand that. If I can ask the question that Greg asked in a sort of blunter way. Everybody's been clear that the decisions that were taken would damage people's health because of the withdrawal of health services and of the economic damage that was done. There was going to, again, did you, as the government's chief scientific advisor, recommend that there should be a paper that tried to quantify that across different areas? Because basically when the decisions were being taken, you were deciding that people who had onset cancer, people who needed transplants were going to die. I mean, it's as simple as blunt as that. Did you say that we should try to model this and work out the numbers?
We definitely flagged that the economic risks to health were significant, and CMO flagged that on numerous occasions, and that was well understood by Treasury, and we have pulled together groups of economists and epidemiological economists to talk about measures for preventing spread which take into account both economics and epidemiology with a number of meetings. I don't think we ever said that somebody needs to crunch those numbers on the economic side. We did, however, ask for a piece of work on excess deaths taking into account the economic impact. So that was commissioned as a piece of work for SAGE.
And has it been done?
Yes, it was done, yeah.
Because in order for the government to make sensible decisions, I mean, the excess deaths at the moment, look at it, to be about 65,000. They need to know what the other side of that equation is. And I would have thought it was the role of scientific advisors to say, at the start, this is likely to lead to so many deaths because of direct infection, and then this is going to lead to so many deaths because the health service, or large chunks of the health service, is cut down, and poverty kills, basically, if people lose their jobs.
Yes.
And was that up?
Yeah.
Was that quantified?
Yes. There was a piece of work done on that by the National Statistician.
And what were the numbers?
I can't remember the numbers off the top of my head, but the National Statistician did a piece of work on that for SAGE, and that's, I think, must be in the public domain already.
Right. We'll find that then.
Move on, Graham.
Okay.
So again, we go to Aaron, then you've got a couple of questions on
I've got a couple of questions on testing, but we can come back to them.
We'll just come back to that. So Aaron Bell had something on monitoring and surveillance, I think.
Thank you, Chair. Just to talk about the current monitoring and surveillance, Sir Patrick, what's the current time lag in R values for the country as a whole and for individual regions? And to put that into an example, are we already able to detect the effects of the relaxations that we made on the 4th of July?
Time lag for the R values that are published is roughly 2 to 3 weeks because they rely on a number of inputs, including hospital admissions, ICU, deaths and so on, of which there's an obvious time lag. So the R is a lag indicator. There are ways in which you can do R which are more concurrent. So, for example, there's one particular approach run from the London School of Hygiene and Tropical Medicine called COMIX, which looks at contacts. So it's not looking at outcomes, it's looking at a contact survey, which gives you a more proximal measure of R. And the ONS survey, which is measuring infections, gives you, again, a more proximal measure of R. So it depends which value you're taking. The other thing I would say is that as numbers come down and are much, much lower, R becomes progressively less useful as a measure for the simple reason that it jumps around a lot with a few cases here or there or an outbreak, and it becomes really not a very blunt and lagging tool in which to judge effects.
So in terms of communicating with the public, is overall prevalence at a given time a better measure for people to understand what's going on with the current decline and potentially the future spread of a second wave?
We think prevalence, incidence, outbreak measures, those sorts of things are more relevant going into a lower overall prevalence state than R or growth rates are.
And given those time lags you spoke about and the alternative measures, what's our best early warning signal of a second wave? Would that be through that data that you've just spoken about, or are we going to have a time lag before we realise that we might be in a second wave?
No, it's looking for things like increased number of positive tests as a proportion of total testing, sort of thing that was done in Leicester. That's exactly why the Joint Biosecurity Centre was put in place, to be able to monitor those sorts of numbers through test and trace, and use a number of... what we recommended from SAGE was a number of different data streams should be used to look at this going forward, including that, but you could imagine other things as well, such as monitoring absenteeism rate and so on, gives you early signals as to where something's happening. But at the moment, it's based on testing.
And are those data sets and data streams, are they some of them publicly available, all of them publicly available, or is it mostly private?
I think the intention is that they should be public, but again, that's for JBC and Test and Trace to comment on.
Okay, thank you very much.
Thank you. I'll turn to Catherine Fletcher next, but just on the R number. Have I got this right in that if we get to a position, say we had one person infected with COVID in the country, and they infected 5 people, perhaps they're on the Isles of Scilly, the national R number would be 5.
Correct.
And yet, so therefore, it seems to me a poor guide to policy. What you want to know is the prevalence, the number of people, where they are, how containable it is. Why has R had this iconic, almost mythical status?
Well, it did early on in the epidemic because it was the right thing to measure there, and as you may have noticed with the language I've used at the podium several times, it's not the right thing to be using now, and it's been true in every country. I had an exasperated call with a colleague from Germany who was talking about how he was being asked to give R values every day and how they jump around and don't make any sense. And the latest bit that we've got on our website is low case numbers and or high degree of variability in transmission across the regions mean that the estimates are insufficiently robust to inform policy decisions. So we agree.
Very good. Thank you. Catherine Fletcher.
Hello, Sir Patrick. You've been at this a good while now, since half 2, and I am aware that it's not living the quietest 4 months of your life, so I very much appreciate your time. I was hoping to pick us up from where we currently are to look at treatments and vaccines and to understand what SAGE's view on the likelihood is of those and what we can look forward to as additional measures apart from just transmission spread. So if I start with therapeutics, is SAGE working on anything in the therapeutic space, or is it again just receiving data and feeding that in?
Can I give you my views and the views of other scientists who are feeding into this, because there are specific task forces working on this, and these are not topics which are coming to SAGE. So SAGE is not looking at specifically at therapeutics or vaccines. So on therapeutics, where we are as of today is that we've got one antiviral, which obviously has some effect, which is remdesivir, which seems to shorten hospital stay but hasn't yet shown a decrease in mortality. You might expect that if that were to be used earlier, it's possible its antiviral effect would show some bigger action, but that hasn't been done yet. And then dexamethasone, which was the outcome from the recovery study, which does reduce mortality in patients in hospital requiring oxygen therapy, and there you get a sort of 25% or so reduction in mortality, a very important finding which can be applied across the world. There are more studies to read out, so there are studies from generally existing drugs that have been repurposed for this, and those should read out over the next few months, which may give further examples of where you can use drugs to try and reduce mortality. And then there are new drugs coming along. So, for example, there are antiviral drugs which are now much more designed for this virus rather than the other ones which were designed for another virus and have just been tried on this one. So there are protease inhibitors and messenger RNA polymerase inhibitors which are coming along, which may have a bigger effect. So in the therapeutic space, lot to be done. One of the things that we need to do in this country, I'm absolutely sure about this for winter, is to make sure that as many patients as possible are enrolled in clinical trials, because that's the way we get the answer. It's the way we found out hydroxychloroquine didn't work. It's the way we found out the way that dexamethasone did. So clinical trials, very important for winter. Vaccines.
May I just, I apologise for interrupting you, but I think it's worth actually highlighting what a remarkable effort the British public have made in participating in these trials to date, and how they're contributing to science that is not only helping the British public but the world. I'm sure you'd want to put your thanks to them on record as well.
Absolutely, it's brilliant. I mean, the recovery study had over, I can't remember exactly what the numbers are now, it's 12,000 or more patients enrolled. It's absolutely impressive, and that's people volunteering to be in trials, which is a fantastic sacrifice to say, yes, I want to help somebody else by being in this trial. That compares with, for example, the WHO Solidarity study, which is a multinational study, which I think has currently enrolled about 6,000 people. Incredibly impressive that what's been done with recovery. Vaccines, there are, I think, over 100 vaccine projects across the world. And there are some that are in the clinic and are leading. And the one which is at the front at the moment is the vaccine from Oxford, which is in phase 3 clinical trials in thousands of patients. That's a fantastic position to be in, and the UK has got itself well sorted out, and I was very involved in this at the beginning and stayed close to it, in making sure we've got a wide range of vaccine options with different mechanisms, different approaches, because we don't know which one's going to win, or indeed whether more than one will win. All you can say is, and this is a bit gloomy, but it's true, the most likely thing for any single vaccine programme is it won't work.
Catherine?
So you need to make sure you've got enough of them in order to do it. And I think we're in a pretty good position.
Well, just let me understand very quickly, when are you making any assumptions about any one of those multivariate bets coming off in terms of the way the scientific advice is being structured to government?
Well, the Vaccines Task Force, which Kate Bingham leads, is absolutely looking at what are the options, what are the modalities, where are they in the proof stage, how far advanced are they, what are the manufacturing implications of this, and how does that feed through also into vaccination policies. There's a very integrated approach to looking at the overall options and making sure that we get the chance not only to be part of testing them, but also, of course, access and application of these vaccines. Doesn't mean we're going to get a vaccine, doesn't mean we're going to get one soon, but we've got the bets covered, I think, in a very strong strategic way. We're giving ourselves the best chance of getting something.
But our approach right now is not making an assumption that something's going to appear over the horizon.
No.
We know we're well placed for that, but we're planning as if we don't have it.
I think our assumption is we won't have it, and then when we get it, we'll be thrilled.
Thank you very much, sir.
Thank you, Catherine. Just before I go to Dawn Butler, on vaccines, you mentioned the Oxford study is conducted by the Jenner Institute, I think. The director of the Jenner Institute today has called for challenge trials to take place, in which healthy young volunteers will be deliberately given coronavirus after receiving the vaccine. And he said that if challenge trials can safely and effectively speed the vaccine development process, then there's a formidable presumption in favour of their use, which would require a very compelling ethical justification to overcome. Do you share that assessment?
Well, human challenge studies for vaccinology are well established. So there's nothing new in that concept. It's a well-established way of testing vaccines. What are the two big challenges for this virus? Dose and rescue. So the prerequisites that you need to have to do human challenge studies are to understand what dose causes a safe infection, and can you rescue it if you get it wrong.
And what's the current answer to those questions?
We don't know the dose, and we don't yet know that remdesivir will rescue the infection.
So not yet.
So I think absolutely the right thing to explore, but we're not there yet in terms of having the answers, and we need to make sure we progress safely in terms of understanding. And you won't know the dose just because you can dream it up. You need to find out the dose, but there are ways to do that, and you can test whether remdesivir could rescue. But those are the things I think which are going to be the ethical considerations that people will need to think about.
And work is going on to be able to answer those questions.
Yes.
Thank you. Andrew Griffith had, I think, a brief question, and then George Butler.
I think when you spoke to this committee previously, I was certainly left with the impression that therapeutics might be more proximate and more likely than a vaccine. A vaccine sort of at that point was the moonshot, therapeutics was potentially down the road. What else is going on in therapeutics?
Well, just a word on vaccines first of all. I think it's also important to recognise the chances of having a totally sterilising vaccine, i.e. one that 100% protects you from this, I think are low. Much more likely that you have a vaccine that reduces the severity of illness and reduces spread a bit. So I think that's the more likely outcome on vaccines. On therapeutics, as I said, I think there's a lot going on now in two main areas, or maybe three. One is how you deal with the inflammatory response, which are the studies which should read out relatively soon, and there are more starting there. Antivirals, which I've mentioned two classes which are being pursued, and there are many others as well, and then potentially preventative medicines as well, which are being looked at. Those are the three big buckets, and they're all being looked at. And I think it's right that the therapeutics is more proximate. We've got dexamethasone, we've got remdesivir, and we'll see what comes next.
And what's the intervention? Sorry, Chair, just so I understand the work that Kate is doing on the vaccine side, and I think various witnesses have given us a good sense that almost every study is being done, and Sir John Bell's leading a lot of work about how we do that. On the therapeutic side, is there an equivalent of that initiative, or is it by its nature much more
It's different. I mean, again, just to be clear, it's Kate and the Vaccines Task Force that's leading the vaccines work. Yeah. I mean, on that. On the therapeutic side, it is different. Because the issue with vaccines, and the reason we set up the Vaccines Task Force, was because vaccines require manufacturing capability in a way that's a bit different. They have a different need in terms of clinical trials, and in a way, you're more likely to end up with something that can come through different routes like academia than you are with some of the drug things. The drug things are largely in the area of big companies and innovative SMEs and so on with therapeutics. So they will come up wherever they come up. The manufacturing is a different issue. It's really about trials. So the question there is, can you get the trials right in order to be part of getting the answer?
Thank you.
Thank you, Chair. Thank you, Sir Patrick. Talking about vaccines, actually, we took some evidence, and it was really quite interesting to hear that we are ahead of the game in any other country. Health literacy is absolutely vital in regards to fighting coronavirus and the spread. People understanding what their role needs to be in fighting this virus. And I just wanted to know your views on a couple of things. Number one, ensuring that we have all information translated into various languages. That includes British Sign Language. We know there's 11 million people in the UK who are deaf and hard of hearing, and now that face masks are compulsory, they won't be able to lip read. And also we understand that the UK government's virus task force has 47,000 British, Bangladeshi and British Pakistani volunteers. And I'm just wondering your views on making sure that all of the information is provided in different languages to help the science and to help combat the virus.
Yeah, we've said in our behavioural science subgroup been very clear that that is absolutely essential, and have gone a little bit further to say that many of these things need to be co-created with those communities. In other words, it's not the translation problem, it's actually how you get proper co-creation. And the third thing is that I think very often community leaders need to be engaged with this as well, because it's not simply a sort of information, I've given it to you, it's done. It's an engagement process. So we strongly agree with that. And the report from the Academy of Medical Sciences, I think, made a very important recommendation, which is that there needs to be a strong and comprehensive public information and engagement campaign in early autumn in preparation for winter. So strongly agree with your point.
And the face mask people being able to lip read when face masks are widespread?
Well, I don't know what the answer to that is. I mean, it clearly is a big, one of the many big issues. There are others as well. So, for example, I've had colleagues, respiratory physician colleagues, who've spoken to me to say that their patients who've got chronic cough for other reason find themselves being stared at and shunted out of shops and things because people think they should be at home isolating, whereas they've got a reason to have a chronic cough. So I think there are some quite important things to look at here in terms of how we deal with all of these areas and how we make sure that we don't end up with people being selectively disadvantaged. And it's striking and incredibly depressing that this virus has not only exposed inequalities, but it has exaggerated inequalities. And that is a very important thing for us to keep in mind in everything we do.
Absolutely. Dawn.
And just one practical question. Mobile testing units. Should we not have mobile testing units at large workplaces where there are, say, 1,000 people or so, or 500 people? Would that not help in regards to understanding the virus and how it spreads? And if you take Parliament, for instance, we do have an issue with potentially creating super spreaders. And so having a mobile testing unit in Parliament, even if it's just an ad hoc basis, will help you in tracking and tracing if there is an outbreak of virus.
So I'm in favour of testing in occupational settings. As I said earlier, I think there are occupational settings that do benefit from testing, and we have also asked for a piece of work to be done looking at transmission in different environments. It's going to be led out of Health and Safety Executive, but with academics involved as well, because one of the surprising unknowns, and is we don't really understand the routes of transmission of this virus, as I said, and so we've got to do much more work to do that, and occupational settings are a good place to do that.
Thank you. Thank you.
Thank you, Chair.
I think Graham String had a couple of questions on testing.
Yeah. Thank you very much, Sir Patrick, for this afternoon. You've drawn the short straw, getting twice as long as you were.
Yes.
But it's been very, very interesting. I've got a couple of questions on testing, but you just said something about a major public information campaign this autumn, which I think is important. Do you think that should also include a major campaign on flu vaccination? Because if we get a major flu outbreak, it will make things worse. And similarly, or along the same lines, do you think there should be an intensified campaign to get the lifelong pneumonia vaccinations, which are given to the over 65s, which may help with this? And sorry, this is a long question, it didn't mean to be. And should we intensify the pressure on care homes to make sure their staff are vaccinated for flu? Sorry.
Well, they are. I mean, we're going to sort of agree to differ on operational points, but these are important questions. And on the flu vaccines, we flagged up a long time ago that this needed to be a big flu vaccine season. DHSC understood that and have, I think, taken steps to procure vaccines. You don't procure vaccines now for winter, you procure it several months ago. Yeah. So this was something on our radar right at the beginning to say flu vaccination this year is particularly important.
When do you start vaccinating people?
No, not now. No, it's later in the year.
When?
You need to
September,
you need to put
October?
the order in
Absolutely.
now in order to do
but
it.
When
So
does
it's a
that
normal flu vaccine. I can't remember exactly when the programme starts. It's sort of autumn time, late autumn. The vaccine
late autumn
programme starts. So that I think is understood, and the Joint Committee on Vaccination has given advice on what the vaccine group should be, who should be vaccinated, and they've looked at the whole breadth of vaccination. So I think that is covered, and you're right to raise it. It's very important.
Thank you. Obviously, just going to testing for this particular virus, the virus has to be done a sufficient number, and it has to be accurate and of sufficient quality. Do you believe that the polymerase chain reaction tests are good enough?
PCR is very accurate, no question about that. But that doesn't mean the test is very accurate. So what do I mean by that? We know that you get false negatives, and those false negatives can be quite high at certain times of the infection process. So there are three main reasons for false negatives. One is it's early in the infection and the person isn't shedding enough virus to be detected. The second is that the swab itself hasn't been done adequately. And the third is the PCR's a false negative for some reason. And of those, the PCR false negative is by far the lowest. I mean, that test is pretty sensitive and pretty good. So it's really swabs and timing which are really important. And you can see, if you do it at the wrong time. So if you test somebody, after a few days after they were infected, before say day 2 or day 3. I can't remember exactly off the top of my head, but it's a sort of 30% or so false negative at that point.
That's very high.
But it's not the PCR. And then the other thing that's quite exciting is new technologies coming along, so-called LAMP technology, which allows a much faster and easier test, which is essentially measuring the same thing as in PCR. And I know there are studies going on at the moment to see if you can pick that up from saliva, which would make things much easier than the swab.
Well, we need extra capacity in the autumn when children go back to school and the weather changes.
Yeah.
Can you put a figure on it?
I don't know exactly what the figure is, but we need to continue to ramp up testing. I mean, I can't remember where we are at the moment. I don't know exactly what the numbers are. It's I think at least 200,000 a day, I think, and it's going to go up higher than that. So we need very high level testing, and that's why something like LAMP and saliva would be really good. If it was very easy and you could do it quickly, you can then really think about much more widespread testing.
Right, thank you.
Thank you, Grim. So just on that, you mentioned, Patrick, the Academy of Medical Sciences report, and that made the point that as we get into the winter, people are going to be presenting with symptoms that may be COVID, or there may be other types of, it might be flu, and therefore need to be tested. And they put a figure of, I think, over 350,000 people a day being required to be tested. Have you made an assessment of whether we've got the capacity to meet that?
Well, we haven't got the capacity to meet it at the moment.
We haven't?
At the moment, no.
Have you seen a plan to develop it in a critical way?
I believe that plan is being developed.
Because otherwise we're back to where we were in March.
It's essential. And the other question on this is whether you can, what's called multiplex testing, so whether you could do something to test for multiple respiratory viruses at the same time, which would then allow you to say, you've got flu plus COVID, you've just got COVID, and triage much more effectively. And again, this comes back to the economic point, which is there's a very big risk with multiple respiratory viruses circulating that you end up isolating a lot of people who haven't got COVID. Absolutely. And because of the false negative point that we've just discussed, just because you're negative doesn't mean you haven't got it. So that's why isolation is important. So multiplex testing, where you can also get a positive on, yes, that's flu, I think becomes quite an important part of this.
I said right at the beginning of our session that part of the point of asking these questions is to be able to learn lessons that inform decisions on the way. And this seems to me a classic case of this. The one thing that we've learned is that we didn't have enough testing capacity early on, so it needed to be rationed, it needed to be confined to hospitals in the first place. So this seems to be a matter of consensus now. So we must learn that lesson and apply it to make sure we have more than enough testing capacity in time for the autumn and winter, must we not?
I completely agree.
And do you think that is fully understood and being acted on?
Well, it's fully understood and it needs to be acted on. And again, it's as an advisor and as Sage, I can't make that happen. But I think it's important that it does happen. I believe it is happening. I recognise that is a crucial thing to do. I've talked to you about multiplex testing as well as another thing. I've talked to you about the LAMP approach to try and get a more widespread testing. I don't think anyone's in any doubt that getting the testing right is important, and it's a fundamental reason why funding organisations like PHE and JBC is crucial. And if you look at the countries that learnt the lesson of MERS in 2015, they funded those systems well. And other countries around the world that saw what had happened funded those systems well. So the funding of our public health system is a very important part of preparation, not only for this, but for future problems.
And the responsibility of that, as you made clear during this hearing, is with NHS England and the Department of Health and Social Care, and we'll have the Secretary of State and the Permanent Secretary next week, and we'll be sure to ask about that. But my the final and related question is that early in the pandemic, the committee took evidence about the projections, the modelling projections as to the number of cases that we would have, and obviously one of the pivotal judgments was whether NHS capacity would be swamped, whether it would be exhausted. Have SAGE made that same assessment of where we are for the coming winter?
Well, as you know, the Academy of Medical Sciences report, which we commissioned, has done that, and it's made some assumptions around that, and we're in the middle of doing further work on that at the moment. The one thing I'd say about the Academy of Medical Sciences report is they made an assumption that R would be 1.7, just as a sort of modelling assumption. And of course, that is literally just an assumption. So we're going to go through and work and see, make sure that we've got that ready for...
We read in the newspapers this morning that there is investment to be put into the Nightingale hospitals. Are we to infer from that that the normal capacity of the NHS is not going to be sufficient, so we can expect a caseload that is in excess of that standing capacity?
Well, I think it's reasonable to assume that you need, to be resilient, it's sensible to have that. We don't have any prediction at the moment as to what the numbers are, and of course there are other catch-up things that the NHS is dealing with as well. So I think, again, those are really questions for the NHS, but it seems to me entirely sensible to think about resilience in the system.
Absolutely, thank you. And it's been very helpful to understand the where SAGE can give advice and where it is not appropriate. So to give a final example of this, does SAGE give advice on, for example, whether it's safer to be in an aeroplane than a theatre?
We would not give that sort of comparative advice. What we would do is give advice on the principles of environments and how one should do a risk assessment in environments. It may be then health and safety executive or somebody would be able to take that down to the exact level of this environment versus that environment. What we have done, though, is a piece of what we've asked for is it possible to measure COVID security in an environment, which is very difficult to do. So we are looking at what the true assessment of that might look like, and I'm not optimistic you've come up with a very concrete answer.
So Patrick, you've been very generous with your time. We're very grateful. I want to reiterate what I said at the outset. Our purpose in this inquiry is to try to draw lessons that can be of value during the pandemic and beyond. The way that science proceeds and your eminent colleagues practice this all the time, is to ask some difficult questions and to produce some answers that may require a change of practice. Right from the outset, you've participated in that spirit. Very grateful for your continued engagement with the committee and for the very important work that you do on behalf of the country with those of your colleagues. Thank you very much indeed.
Thank you.
That concludes the meeting of the committee. Order, order.
Technology Committee, the Thatcher Room, the 16th of July. Science and Technology Committee, the Thatcher Room, the 16th of July. Science and Technology Committee, the Thatcher Room.